So I'm very excited to host the first AIVF company session at ESHRE and to many more. And what we wanted to do today is form kind of like a playbook of how to incorporate and integrate AI systems in your clinics. What we're seeing now is that there's a, hi. Sorry, what we're seeing now is that there's a shift in the industry from a proof of concept to real products that are commercially available. And I think, when we started 5 years ago, there were many skeptics in the industry that are now becoming our main champions of AI and how to do better IVF care with AI. So we asked here some of our great partners, clinics, who've been working with us for about a year. We're now commercially available for about a year now, working in Europe, in the US, Southeast Asia, and South America. And we wanted to share with you some of the experiences that they have and talk about big things that we usually don't talk about, like ethics and patient engagement and how we market you as clinics, how you market this AI and data privacy and cybersecurity, and all of these and more. We'll have our amazing partners here, and we'll be hosted by Professor Daniel Zeidman, who's also our co-founder and chief medical officer, and Dr. Marcus Messiger, a world-renowned embryologist and one of our greatest partners and friends. And thank you very much.
Thank you very much.
Okay, thank you, Daniela. Thank you for all of us, for all the people joining us. We prepared some questions, but again, if there's any questions from the audience, this is going to be great. We have a great expert faculty, all have practical experience with using AI in the lab, so they can really give us some really cool answers. So we're going to call each one and we'll introduce them as they come, so we don't have to take too long. So maybe we'll start with Ricardo. Ricardo is an embryologist and a professor at the University of Naples. He's a PhD in reproduction, a professor of reproductive biology at the University of Naples. And I wanted to start with this classical question, should embryologists be worried that they'll be replaced by AI, or do you think this is a complementary future?
No, not at all, that's for sure. So artificial intelligence should be very helpful tools for embryologists. I think that all our knowledge should be shared with the informatics to build robust programs that can help us to choose the best embryos. My questions is basic, fundamentally. So I am a clinical embryologist and a basic scientist. As a basic scientist, I know very well that what we are doing now in culturing embryo, we are not mimicking the right way what happened inside the reproductive tract. So generally, the embryo development is something that is not static, is progressive, and also experience different substances and concentration of substances during the long way from zygote to the blastocyst. So I think that artificial intelligence should help us to choose the best embryo in the static condition, but should move also to something that could be more efficient to study what happens during a dynamic embryo development. So I think that for now it's fine, but we have to go further for further steps.
Ricardo, but do you think that the role of the professional in general may change slightly, or that maybe we are going to need less train or train embryologists or with less degree of studies or things like that because the AI is going to replace some of the work that we are actually doing or not? What do you think?
No, I think that could be useful also for training the people in the lab, and at the same time could be useful to combine the tools of a real embryologist. So I think that could be useful tools. For sure, in my mind, does never blind the embryologist.
Good to know. There are some Achilleas. Yes. Let me introduce a little bit, Achilleas. You're lab director in Greece.
Yes.
Which is, for me, one of the also the most important countries in IVF in Europe. You are always in the top of the technology, open-minded, I think, culture like Spain, I will say.
Yes.
So we see very, very similar.
We are very similar.
And I would like to know your opinion, also like an expert.
Yes. Well, what I would like to say is that AI I believe that it can never replace the expertise and the knowledge of an embryologist, and also can never replace the decisions that we can make. Okay, so AI can help you with the data analysis and management of great and huge pack of data. So it can help you take better decisions based on bigger data. Okay, and it can also, as you know, it can help us with image analysis. A very great example is what AIVF is doing with the image analysis that the software it's giving us. It's going to help us take probably better decisions or verify the decisions that we take. But it can also help you with patient management. I mean, imagine if you digitize your whole clinic, you will be able to connect with your patients, give them applications. And believe me, we've done that, and we involve them in the treatment by uploading their exams and by giving us more and more data. And all these things are there to help you, not to confuse you, and probably give you more time. And especially if automation comes, I mean, it is actually coming, I guess, but probably in the next 5 years or 10 years. It's going to help you do ICSI, select sperm, and all these applications. I think it's going to give us valuable time, especially this era that everything is so confusing and so demanding from an embryologist to do in the lab. It's going to give you a valuable time to probably think or probably do some research, as you said. So that's my opinion, my perspective on AI.
I remember to the audience that here we're just trying to bring some experts in the field that have been using the technology and all the questions related with the introduction of the technology, and also the first of what is going to happen in the future and what is our expectations. This is why we have this panel here today, and I would like to listen also other opinions about this.
Yeah, Alexia,
Yes.
please. Alexia is also a senior embryologist and a leader in her field in Greece, and she has experience with AI. So
I'm going to talk as a risk management professional. The situation that has been formed over the recent years with the introduction of PGD, of vitrification, fertility preservation, has created a more or less unrealistic situation for us operating in embryology lab, as we need to perform and outperform ourselves by doing simultaneously more than one tasks when the system has zero tolerance for mistakes. So this is unrealistic and sometimes overwhelming for every one of us. We are just human beings. We are not superheroes. Superheroes are not part of the reality. So how can one work with the basic training, knowing that they have no tolerance for mistakes in this very busy and very demanding environment? And while they operate under pressure, they need to make critical decisions, such as which embryo to transfer, which oocyte which oocyte is the best to proceed, or which sperm to select. And at the same time have all these patients' expectations to manage. So yes, I see that there is no future without embryologists, but I see the need to relieve them from tasks that can be replaced from AI, so they will focus on more relevant tasks that are more close to their human nature, so they will feel less stressed and more able to do the complicated tasks that cannot be performed by the AI.
So Alexia, in this line, you mean that this technology potentially may help us to increase the capacity of our labs to manage the work that we have daily? I mean,
as
keeping in mind
Achilles
that
pointed out, we want to increase the time, the availability of time. So embryologists would have more time to invest on patient care, individualization, without worrying which embryo to transfer, or all the daily tasks that arise every day. If they can be relieved about for example, the safety issues of a cryobank, because AI may soon interfere there. The following up of the KPI parameter of the culture parameters, and everything is controlled by an AI system, then yes, they will feel more secure for the cultural system and for the safety of the embryos oocytes, and they will invest more time into training or train others. Can you imagine the later future with less embryologists than we have, when the demands for IVF cycles increasing, and the estimations are that we may have like double number of cycles in the future? How can we do that when creating a practically very stressful environment for the embryologist? This will distract the future generation from joining us. We need to motivate them, to make them feel appreciated and secure.
So that means that probably the AI will empower a little bit our position in the lab, or the position of the embryologist?
It will empower our patient, our embryologists, empower our patients because they will feel safer, and improve the efficiency, hopefully, by helping us make better decisions and less operated related. And hopefully will increase the motivation and inspiration of embryologists to join our field, or prospective embryologists to join our field, and help them understand that they are well protected in this area and not exposed to unrealistic stress levels and burnout syndromes. The efforts need to be visible and appreciated to us. So they need tools, they need all our supports to perform their daily work hidden in their labs. We know about that.
What about training? Do you see AI making, because you suggested you talked about the new generation of embryologists, so do you think AI will help us train them, or maybe they will actually lose some of the capacity because
train them, support them, or create time for us, the embryologists, to train them. Creating a new generation of embryologists is crucial. We need lots of them, fastly trained, but as well protected as well.
Yeah, this is not happening in other countries, Alexia. I know that probably in Greece, like in Spain, there are quite a lot of embryologists. At least in Spain, there is a lot of embryologists, and we don't have this feeling of shortage like there is in other countries.
There are countries that import their embryologists. We have them. We have people that are coming from other countries while they are of other nationalities, because there is so big shortage of embryologists in the countries where they work, so they were kind of imported. It's a global problem.
Yeah.
Definitely. I mean, we feel this in Israel. There's a big shortage of embryologists. I'd like to ask David Walsh, who is a very experienced and knowledgeable physician. We just heard the embryologist side. So I know that you're an early pioneer of AI and a leader in Dublin. I mean, you've directed several IVF units. How do you see, as a IVF unit director and a doctor, AI? Will it really increase our capacity, increase our capabilities?
I think the word that comes to mind really that was used by Alexia was empowering, because the truth is we all need that. Embryologists need it, but so do patients and so do clinicians. We've been using the system for almost a year, and it has significantly boosted the probability that an individual would become pregnant, particularly with frozen embryo transfers, where we have an opportunity. Now, the converse of that also is that we also have an enhanced ability to know when a pregnancy is less likely to occur. And more importantly, if you have a very high-grade embryo, like with any circumstance, and that patient does not get pregnant, then at least as a clinician, you take most of that heat in the consultation room. And everybody here who actually faces that situation knows that if they have a patient and they don't have any answers to why it didn't work, it's a very emotional space, both for the clinician and for the patient. So any tool, and this is a very powerful tool for assisting in that selection process, so to enhance the probability of success, to increase the probability that you have at least some plausible explanation as to why it didn't fail or why it did fail, and thirdly, of course, to give you confidence that if you're going to investigate for all those things that we do eventually look for, occult infection, the receptivity, hostility, all those various elements that we can look for, minor Asherman's, minor syndromes. So it's very much a clinical concern. And I do think sometimes if it's just focused on embryology, the heated space that every clinician has had is a real-time event, and any tool, and this, I can tell you, this tool really helps, and I hope our medical director can speak to that. So from a patient point of view, it empowers their decision-making, it helps us to assist their decision-making, and it makes it much more probable that we can help them succeed and learn if they are failing.
Because David, one question, my feeling when I see the interaction between the doctor and the patient is that in many cases the doctor does not have enough time to provide to the patient care. I mean, because they have a list of patients to visit in the day and they are demanding more information. Actually, if you take a look to some of the Instagram pages, you start to see like counselors of patients that spend like 1 hour talking with the patient, explaining things that in the consultation were not provided because of the lack of time. Do you think that AI is going to be able to provide that extra information that patients need to feel totally comfortable with the treatment or totally informed about all the details of the treatment?
Well, I mean, there's only three things in your mind when a patient fails, because any fool can manage success. But is, did the embryo have the capability of becoming a baby, or realistic probability? Was the transfer gentle, and was the environment into which the embryo went receptive and had the ability to accept it? So any tool, and this includes AI, which gives you confidence one way or the other on at least the first part of that journey, is really helpful, both for the patient and, more importantly, for the doctor as well, in the sense that if the doctor has more certainty and confidence about their ability to know what worked and what didn't work, they can then transmit that to the patient, and that will give them comfort. And I think I'd be interested in what...
So do you think this will actually increase patient engagement? Because AI can graphically and numerically, present more information to the patient. Do you think we should encourage this, or do you think that we'll see patients demanding to see more data on the embryos?
Yeah, I think the patient look to the professionals to provide that information, and the clearer the professional is about what they should be doing, the better, and the patients will perceive and get confidence from that. And in addition, they'll have learning. So I wouldn't have any concern that, in some way they're going to be using that disadvantageously for themselves or otherwise. I think most people are very reasonable, and the more understanding they have, the more empowered they are, to go back to Alexia's term. I think this tool it really does empower them, as well as the rest of us who are trying to assist them.
Thank you. Conor, can I come here? Conor Harity is the director of the first IVF lab, and his experience with running IVF. So I wanted to talk about the security concerns. The moment you put digital technology into a lab, there's a lot of concern. You always have an IT specialist coming in saying, no, you can't produce this data. How are you meeting these challenges?
Yeah, well, we actually had this in our public health service. Our hospital got hacked, and a Russian group hacked in, and for 4 days we lost access to our electronic health records. So about 4 years previously we had used paper charts, and we made a very difficult transition from paper to electronic, and we realized all the benefits in leaving that old system behind. And what we learned from that was what extra layers of security need to be employed before you can make that change. So I think with any personal data, there has to be security. So if we're recording patients' information, their embryos, it has to be secure. And the IT security industry now is growing rapidly. There's so much technology out there to keep it safe, so it's a matter of integrating those safety nets into the software so that there's no way of getting unauthorized access to the patient information. So it seems to be a very well integrated setup. We certainly have no concerns whenever we record the patient information on our software.
What about cost? Do you see AI as a cost saving in the lab, or is it just an additional cost that will be a challenge to the patient?
So in terms of costs, we have to ask what are the alternatives. So ideally we'd like a routine embryo selection for all. So it's not just some patients select PGT, others we just use morphology. Ideally we want to get a technology that can be used universally for all patients. And the benefit of AI is it can be used universally, and then when we find those embryos that are in the gray zone where their scores are low yet the embryo looks good enough to transfer, we can then identify a cohort of patients who we may then want to proceed and biopsy those embryos. So if we can move to a more cost-effective universal screening, then it has cost-saving implications for the patient. So the cost of incorporating AIVF when compared to PGT, it's much more in the right price range for the patients.
I would like to listen from the panel about the cost for many reasons, because we should, let's say, to find a justification to introduce the technology, and you may think, first of all, we would like to see, which is going to be, for me, almost impossible to demonstrate that there is like initial an improvement in the outcome. You know how complicated are the trials, and even that it became old-fashioned when you start with a technology that is continually evolving and making it better. So that is going to be difficult. The other part is that you may demonstrate that you are improving the efficiency, that may reduce the cost. Or additionally, one of the, I think, the hot topics of, or the most attractive thing that I would say that I've seen from AIVF is the potentially to use the non-invasive PGTA, because that's very evident. So in front of your financial personnel in the company that is going to ask you, why am I going to spend this amount of money that will reduce my benefits in the clinic, should be a reason behind. You have to demonstrate me that we are going to save money logistically, we're going to improve the efficiency, or alternative, we're going to offer a new treatment to the patients that maybe the patients are willing to pay. Because at the end, any technology that we introduce in the clinic, if it's not going to be reflected in any of these reasons, it's going to be very complicated to justify the introduction of the technology. So I would like to know your feedback on that. I mean, which are your thoughts, or the way that you may think that may be introduced, thinking in mind that it's going to cost money, for sure.
Yeah, no, it's very cost effective. From an embryologist perspective, it saves time. So they're spending less time grading embryos, less time selecting embryos. We can just look automatically at the scores for the batch of embryos, and it becomes clear cut. We pick the best embryo. Sometimes we have debates with patients. It could be a 10-minute phone call. Do we transfer one embryo? Do we transfer two embryos? If we've got a single high-grade embryo, we know to transfer one. If they're more borderline, we then may recommend two. So there are lots of time-saving opportunities that will then free that embryologist to do their core work, which have cost-saving potentials. And then for the patients, when we're making that choice, do we do PGT, do we not? They're prepared to pay a small fee when they save a large amount in terms of avoiding embryo biopsy and the cost of that. So I think it is cost effective for the clinic, and it's very easy to convince the management team about that. Mm-hmm.
Yes.
That's personally, that's my opinion. I think, but what we would like to do is to invest as clinics to this new technology and, let's say, absorb the cost. I wouldn't prefer to pass this cost to patients, actually. But I would see it as an investment. So to a board in the clinic, I would say, if you want to exist in the next 20 years, you should invest now in this technology. So it's actually the same question you could have with ICSI. Do you charge ICSI or not? Time lapse. Do you charge? Do you have an extra cost? Is it an add-on for your clinic? So I think it's the same way of thinking also with the AI. And I would prefer that we would go that way, to invest as clinics in order to provide the best possible healthcare to patients.
So it's going to be like a differentiation also, or to keep in the same line of the rest of the clinics. If you are in an environment of highly competence between the clinics, you cannot be back, right? You should be at least at the same level, right?
I don't know what's the opinion of the rest of the panel, yes.
So this is a big question because I believe that the IE could be a useful tool, but it's still at the beginning. So there are more confusing elements. So we don't know if we have to choose the blastocyst stage or we have to see the waves after fertilization. So if I am culturing the embryo in some wells, it's different from your culture. So I think it's promising technology, but there are still more confusing elements. So if I had to charge to the patient now, for me it should be my cost, because I have to understand well if it's working the right way. When I will be sure that it's working the right way, I can add the cost to the patient. That's my opinion.
I have a question to my co-chair, Marcus. He's one of the pioneers of time-lapse, and a lot of the research that has been done on time-lapse is his. And there's still a big argument, I think, in the world of IVF. Should we all switch to full time-lapse? That's in my hospital, which is the biggest in Israel. We just switched to full time-lapse. But if you go to the USA, they say there's no role to the embryologist, just put it in a dumb incubator, biopsy it, and see the genetics. So do you think AI will finally lead to recognition of the role of embryology as a whole and morphokinetics specifically?
Yes, definitely here there is an important point, because if you take a look to the technology of time-lapse, of course it has been like a peak and then also moments of totally depressive, I would say. It will depend on the studies. Some of them randomized trials that are really not well done, but are published in very good journals. So, of course, we are a clinic, we are full-time labs, but we have done a lot of research behind. We have generated a lot of knowledge. For us, has been an amazing investment. Definitely, we have recovered the investment in production of science, knowledge, and also quality of the treatments to the patients. But it's obvious that the AI has empowered time-lapse, because now we have seen a new tool that came with the technology, which is the possibility of doing automate totally a process. I will say that officially embryo selection has been totally automatic, and that's something related with the introduction of AI in the time-lapse. So definitely has empowered the technology, and I think they are coming all together. And necessary. We were this morning talking about AI in a different perspective, which is single images. For me, like embryologist, and I don't know your thoughts, it's difficult to believe that just using a single frame of an embryo, you're going to have the same amount of information that just taking a look to the whole embryo development. And this is engaging with the new tool that OAI developed by IVF that we have participated, which is the non-invasive PGTA, or the capacity to identify aneuploid embryos. I think that these type of tools are going to empower time-lapse and AI altogether, because if we're able to overcome one of the processes that we are doing now that is partially inefficient, because all of us know that doing trophoctomy biopsy plus vitrification, even if we are super skilled, some of the embryos will not survive, or some will be partially affected. If we're able to overcome this way of evaluation by using AI, this is going to be an outstanding contribution. It's going to be the super empower of the technology elsewhere, because we are going to be able to offer an alternative to our patients to reduce extremely the risk to transfer an euploid embryo without manipulation. So we are going to have a benefit, which is we are going to avoid to lose all these embryos that in the process are lost because of vitrification and biopsy. And all of you that are embryologists, you know how difficult it is to do a biopsy of the embryo. Of course, you become skilled and it's like your day-by-day work, but it's important, I think, for me, is the most relevant part of the embryology AI tools. There will be tools in another fields of assisted reproduction, algorithms that are helping the doctors in many things. But in the lab, more than embryo selection is the capacity to identify embryos that are chromosomically normal. I think for me is the best contribution that AI can do in the field of embryology, for sure.
So do you think AI without morphokinetics is a realistic option, just using still pictures?
I mean, it's an option because we have to think that still in some countries, I mean, in May I've been traveling many countries. I've been in South America, for example, I was in Colombia. The penetration of time-lapse in Colombia is very low, and even 2 weeks ago I visited Iraq, which is a country still moving outside from a war. They don't have resources to have a time-lapse instrument, but they have at least single images to analyze, and so it could be a good way to introduce AI, but not with all the potential. The potential is taking a look to the whole embryo development, but like a starting point, I like it because it's gonna it's gonna become democratic. Let's say it's gonna be available for everyone. Even the same is happening with the systems that are like IVF that is providing the system through time-lapse, because at the end you are just getting a software. You are not getting a hardware, so it's you can use the technology here in Denmark, but you can use in Venezuela, or you can use in US, or you can use in Iraq. It's going to be available for everyone that is going to be able to share digital information to be analyzed, definitely.
Do we have any questions from the audience? So I will continue with my questions, and anyone in the panel can choose to answer. What about ethics? You know, a lot of people fear AI. You know, they say AI will run us and not we run the AI. But specifically to our field, people are afraid that AI will allow to do sex selection, maybe allow to do genetic selection further on. Are you concerned with the ethical aspects of AI in IVF?
The ethical frame, obviously, it's a concern when you are introducing a new technology with not clear on what are the capabilities and limitations. It's an evolving technology, and until now, it's not clear to any of us where it will land, what parts of our daily routine and work it will affect. Obviously, it aims to become a tool for decision-making to help us make decisions. When these decisions may involve issues like gender selection or IQ, for example, traits that are linked to eugonia, then we need the regulation authorities as well. So we need AI to be regulated in each country maybe, or in a global level, if this is possible, to make sure that we, the practitioners, they do follow the law or the ethical frame, and it's not unregulated, and we may do whatever we want to do or we wish to do. It needs to be regulated while it's evolving. It's a very dynamic and a very dynamic scenery now. So it's like something growing and very fast, and we need to follow and regulate the sooner possible.
So I know there are some attempts for regulation, because it's the first time that we have an evolving technology. You know, the algorithm that we're installing today is very different in 6 months. It learns, it improves. Do you want to add something?
I want to add something.
Sure.
I wanted to add something in AI trying to give you information about sex selection or the IQ, as Alexia said. I'm really concerned because AI gives you a prediction. So how accurate is a prediction about IQ, for example? How can we use this kind of information and to give to patients? So there is a really great concern about the ethical part of it. And then talking about IQ or of different kind of predictions, IQ, for example, is not just a number that an embryo can give. I mean, how can we measure? We're gonna monitor embryos and then we're gonna test the kids and their IQ, and that's it. That's how we're gonna train an AI algorithm. I mean, the IQ is like a more, I mean, it's also depending on your education. It's influenced by genetic, environmental factors, and things like that. So it's not that easy. It's not straightforward, especially for things like the ones that we mentioned. And we should be always aware that, as Alexia said, at some point things are going to change. We might be moving forward to that direction, and that's where we need to stop and set a legal frame and not to allow things like predicting IQ to be available to patients. And
one thing is the end point of the algorithm, that could be that, and the other is, I don't know if you are worried about that, or because at the end, the important is the prediction, or that you know how you have reached that prediction. Is a black box, or is the basement or the rules that has conditioned that algorithm are coming through our own knowledge, because it's something that we have discussed also when we have done lectures or talking about the results that we have done with prediction of euploidy. You have like the deep learning approach, which is you don't know how they are looking for in the embryo, but you end up with a prediction, or the machine learning that is based in your own knowledge. You know that there are parameters of the embryos that are related with any outcome, and you analyze. What do you prefer? Or you don't care?
Yes.
Maybe.
No. Well, let me tell you about that. So when you use the black box training, for example, or the deep learning, well, there is a fault in all this system, because in order to train the system, you should transfer embryos blindly, even the ones that they are not reached the stage of the blastocyst. So can you do that? Can we train a system based on that? So there are plenty of things that, well, I guess that people that work in AI, they have to think about the process that and improve their systems. But how can they improve? And so it's really difficult. Yes. Please come.
So, in my opinion, the ethic problem arises when we will be sure that the AI is working perfectly. Otherwise, it's too early for ethical problem. And I agree with you. The most important thing is just to combine the time lapse with the possibility to choose with the non-invasive methods the right embryo. To do that, we need a lot of research, because we should to combine the time lapse with the possibility to analyze the oxygen consumption or metabolites, other elements. And so in this way, we can buy digital twins that could help us to increase the artificial intelligence. And then when we be sure that everything is working well, maybe we can have some ethical problem.
That's the thing that I feel the need to address it. About the ethical concerns and challenges when it comes to AI implementation, I would like to talk about the ethical way of promoting the new AI technology to the couples, because this should be a part of our concern as well, because through AI we cultivate couples' expectations. So patients may think that AI empowers them to a degree that it's not unrealistic. So I would recommend that maybe sometime on explaining that this is a new, very promising tool, but it has its limitations, and there are borders on what is capable and what is not. a clear guideline that will help and educate not only us, but the patients as well, so they know that it's not a new technology with unlimited capabilities, and they cannot imagine and ask what they have in mind. And while Achilleus was talking, I made a relation. I thought that it's like the nuclear bomb. It's something like the science found it, but only part of its capabilities of this scientific development and achievement are good for the human species.
I think realistic expectations and not over-promising is very, very important. I also think that, because we talked about ethics, that we always should consider the quality of the data that we're analyzing and the possibility of bias, because not only can AI be not accurate, it can also be biased and misleading. So that's always something you have to keep in mind, and always use heterogeneous data, because something that's correct for one clinic in one country might be different in another clinic in another country. Do you have any?
Yeah, totally right. I mean, it depends on the location, and that for sure is definitely different. And again, I would like to ask a little bit something about to Daniel and to maybe to David, to the doctors, because we are talking about, I mean, an IVF probably now has spent more energy in the lab, but what about the consultation? I mean, what about the tools that you can have in consultation to help you, for example, to give to the patient through an algorithm the offset that you are expecting with this patient because you are some data in front of you, or even you are going to prepare the stimulation protocol and you would like to know when is the day of oocyte retrieval, and it's going to be like super helpful and maybe more skilled than you to organize your work, or even to suggest you to do one treatment or another, because sometimes you play with the hormones. Sometimes it's like it's difficult to understand from our side why you choose that hormone on the other, or which dose that you try, or you combine recombinant with HMG or not, or only recombinant, that kind of things.
Well, I'll answer first, then I'll allow Dr. Walsh to complete. I think there are two different issues. One, you're saying, are we going to be frustrated when AI tells us what to do? If we give protocol and we think we're very experienced, and the AI says, no, don't give this injection at this amount, follow my lead, I think this is going to be difficult. The other question, which is a kind of a trick question, on the one hand, doctors love explaining. On the other hand, they even more love the private time to be free. So, and we all know if we start giving patients information, it just creates more questions, and then you end up just showing a picture of an embryo to the patient and wasting, unfortunately, 15, 20 minutes of your time. So I think new technologies like generative AI, which, what we call ChatGPT, that will answer the questions for the patients are going to be amazing. And there's already studies showing that not only does ChatGPT give better comprehensive answers, it's also much more empathic than most doctors, which are always over difficult. So I think ChatGPT already does a terrific job, but in 10 years we'll be totally connected to the AI systems in the IVF lab, and this will save a lot of time for the doctor and will probably be much more empathic. So, Dr. Walsh, do you want to?
I'm going to ask Dr. Hardy to talk.
Okay, good.
Yeah, so I think this is an area of huge potential. At the minute, we're using it retrospectively. So if we get a good embryo and a bad embryo, we can look backwards and we can say what went well with a nice stimulation, what went badly with a poor quality embryo. And another area that we're seeing is ovarian rejuvenation therapy. We're seeing that AI scores are improving with embryos. So as the system learns and we add more information into the algorithms, as we add BMI, FSH, dose, days of stimulation, then yes, I think we'll see that the system will start to help us for this particular patient, because all of the calculators at the minute are pretty poor. You'll put the data in, you look at the dose, and I'll go, 225 isn't right, I'm going to go to 300 and freeze. So as the machine learning improves, then hopefully we will get calculations which will give a more personalized regime. Do we start? Do we step down? Do we increase? You put the follicle sizes. Do you add your antagonist day 5, day 7? Do we measure the LH? So there's so much potential to add these other metrics and patient characteristics in and hopefully improve the stimulation protocol. And rather than just be an embryo assessment tool, it starts to look at the complete cycle between stimulation, embryo assessment, transfer. Can we add in the metrics from ERA, endometrial biopsy, and look at improving receptivity as well? So there's so much potential to grow and improve the whole cycle.
So maybe if we have no more questions from the audience, maybe we'll finish with one more question to to yourself or to Dr. Walsh. How do you convince your administrators? I mean, what a practical advice. I'm an embryologist, I love AI. I'm a physician, I love AI. How do I convince my administrators that this is not just a fad that's going to disappear in a few days and be covered with dust, but actually the next revolution? So,
well, I think part of it is you have to not just talk the talk, but you have to walk the walk. And one of the things we've introduced both on own egg and donor egg programs is a shared success element whereby the patients pay on a repeated basis as they go along, but including when they're pregnant. Because I'm slightly allergic to people telling me I had so many blastocysts, I had so many eggs, they look great, but it's the outcome and the start of that journey is with a positive pregnancy test from the patient's point of view. And I think if we're going to sit from where the patients are, I think we should be sharing responsibility, moving not just at the point of doing the oocyte recovery, but to the positive pregnancy test, to the viable thing. So I think we need to walk that walk with the patients. In order to do that, you need accurate information. And for that, you have to have confidence. And I'm back to this issue of empowering, and any tool, and that includes IVF, that facilitates you in doing that, means you can walk that walk with the patient and accept that risk that you may not get that next portion or that last portion of the funds because the patient's not yet pregnant. So one of the things we've done on our egg donation program is included a cost of a second transfer if you don't get pregnant with the first. Now, you know, I know some people say, oh, we can't be doing that. Well, I tell you, and in the real world, I think we have to do that. I think we have to step forward in that journey with the patient. So it's not just at first consultation, egg collection. It's a continuum. And probably also beyond that time, I mean, you mentioned IQ, but certainly to in the future. I think we should be moving on to viability and on to those outcomes in the future. We have to walk that walk. I don't know if that answers your question. Daniel, does it?
No, yeah, I think in a cost issue it does. But I was also thinking about, you know, you're the director and probably also meet the hospital administrator. So do you see that a problem, or if you convince them that you have a sound program and so on, that's good enough?
Yeah, I was slightly conflicted, partially conflicted when I was listening to the conversation about, I understand the rationale for we shouldn't be charging extra for ICSI or blastocyst or time lapse or any of that. But I think by the same token, patients will understand that if you're offering a premium service which includes all these technologies in, that there will be a price. People aren't silly. They know that will be required. So I think what we need to do is, if we're utilizing all these facilities, incorporate them in, and then there will be a premium cost to that because but you have to provide a premium service. I don't know if that makes sense, but certainly if I'm convincing my CFO, my financial person, then we have to walk the walk for the patients, and I hope that does answer your question.
In order to convince people to follow your steps, you need to inspire them. So the first step, I would say, is an open discussion and a SWOT analysis within the unit to see the capability of the units, because the decisions are based on different parameters, not only based on the science development, but on the location, the size of the clinic, the number of personnel, the capabilities of the personnel. What about the clinic that only provides ICSI, or the clinic that provides the full range of everything? So they will need, on a base-to-base, on a case dependent scenario, to do their own SWOT analysis, and through this see if this is for the benefit of the system. And then they will have to do, we call it project, it's a whole project, the risk management of the project and the gradual implementation of this AI transition period, where from a non-AI AI unit, we are transformed in an AI unit.
Well, finally, I mean, we're finishing, but it's important to underline that also this technology may help us, I mean, if we consider the research in our clinics. I mean, we can have a budget for research because research is important if we want to be a cutting edge in the knowledge and also well known from our patients that we are trying to investigate how to improve. So even to convince our chief financial officer or to convince the board or even to convince the rest of the colleagues of the clinic is that it's going to be a tool available for every one of us in every of the studies that we are planning. For example, in the lab, when we are implementing a new procedure, a new system of culture, a new culture media, a new gonadotrophin, a new stimulation protocol, whatever, and it's going to be difficult even for us if we want to publish our results if those are not supported by some AI tools that are empower our science. So that's another part that is important to keep in mind if we are using this technology, is how important it's going to be for our research, which should be an important part of each one of our clinics.
I certainly agree that research is the basis for this AI advancement, and I think quite a lot of research is going on, and also every clinic we start working with, the first thing we offer them is not only to calibrate the algorithms for their own clinic, but also to suggest research and studies, and I think this is a fundamental thing for any advancement in the lab. Do we have any questions for the audience? So, yeah, we have one question. Can you step up to the micro?
Hello. Thank you for your information you provide us today. I would like to ask if today we speak, can AI overcome some difficulties we face? For example, the variability we face in IVF. For example, we have different type of culture media, different ages. Maybe we have a difficult embryo transfer, so maybe for this reason we don't have a positive pregnancy test. So maybe sometimes we train the system wrong, or maybe we have to have in mind a lot of a billion of data in order to have the right result. Don't know.
Well, I think you asked a great question, but also kind of answered it. The whole concept of, I think, AI starts with big data, okay? And big data is, in the world, it's trillions of points. We know, I mean, it took us 5 years to collect, over 1 million time-lapse videos, and when you have 1 million, then a lot of these technical difficulties start to average out. And also there are tools specifically, we don't have the time to go into it, that can actually factor what's influencing your data. So I totally agree. Does anybody else want to comment?
I mean, I'm totally agree with you. I was literally telling you that AI is going to help us to give all the answers, all those questions. It was engaged with the research. If you really want to know, and it's coming through the KPI that has been by Alexia mentioned before, you have huge amount of data coming from your KPI. You are very difficult to manage, and that may help you to know the right answer. Why I'm decreasing my results, why I'm failing in that type of procedure, or if I introduce a new technology or a new media in the lab, and I would really like to know what is the consequence of that introduction. The technology, this type of technology is helping us to manage all this information that is difficult to manage by ourselves with our own knowledge in the lab or even helping by external statisticians. So the potential is amazing. Especially, I believe that the technology is going to come with an improvement in the results, but not maybe because of the embryo selection. It's because the way that we are going to manage the information to be focused in the things that are really important. Right? That's my point of view.
Okay. And is it focused only in the lab sector, or both in the lab or the clinical?
No, in the clinic, in the management. Even your indicators of the management of the clinic are should be managed by algorithm that may help us to identify where are you failing, where is your problems.
Or for the type of the infertility, for example. that we-
Exactly,
Okay.
exactly.
Thank you very much.
So thank you everybody for participating, and thank you Daniela and the IVF for the support, and to the panel. I think it was a great hour. Thank you all.
Thank you very much.